Good morning, everyone. Welcome to Cardiology Rounds. Today we have one of our cardiology residents, Dr. Kevin Boczar, speaking on inflammation of the heart and the role in atherosclerotic disease. Kevin is in his final year of his core cardiology training. He's also completing the CIP program. This July, he'll be beginning his imaging fellowship here at the Heart Institute for a year, and then we'll be going on to do another year of echo at a location to be determined. So we welcome Kevin this morning. We look forward to your presentation.
Good morning, everyone. Is my mic on at the moment?
Yeah, your mic is on, but we don't see the presenter view.
Can you see it now?
No, we can't. Is there an option to swap screens?
Okay, let's try it here. Is that working there?
Kevin, go to the, you need to go to the bottom right of the presentation and hit the slideshow. Hit this. We're seeing that. Try the screen you had before.
There we go.
There we go.
Okay, perfect. Great. Sorry about that. So good morning, everyone. Thanks for the kind introduction, Dr. Stadnik. Today I'll be speaking about the role that inflammation plays on the development and progression of atherosclerotic cardiovascular disease and potential novel therapies that can be targeted at this player in disease etiology. These are the objectives I'll be doing today. Cardiovascular disease remains a leading cause of death, morbidity, and health economic burden worldwide. It currently accounts for more than 17.6 million deaths each year, and this number is projected to exceed 23.6 million by the year 2030. This somber statistic is equally applicable in Canada, where this slide shows that the prevalence of cardiovascular disease, shown in the light blue color, is only continuing to grow as our population continues to age. One of the greatest triumphs of preventive cardiology has been the identification and subsequent aggressive control of traditional risk factors for atherosclerosis, such as smoking, hypertension, diabetes, and elevated LDL cholesterol. As a result, we have seen a dramatic decrease in the incidence of MI by up to 40% in many Western nations that have embraced this preventative approach to CAD. I feel fortunate to have trained here in Ottawa and that I've had the opportunity to work alongside many giants in this area, including Andrew Pipe in the realm of smoking cessation, Ruth McPherson with her expertise in cholesterol management, and Franz Lenin in the field of hypertension, amongst others, of course. They've all really pushed us forward in this regard. However, despite our best attempts to manage traditional risk factors with contemporary approaches, MACE continues to occur at unacceptable rates in patients with established CAD, with event rates of 10 to 12% at 1 year and 18 to 20% at 3 years after an index myocardial infarction. This is largely because atherosclerosis is a complex disease process whose pathogenic basis extends far beyond intimal infiltration of cholesterol. Inflammation is being increasingly recognized as a major driver of the atherosclerotic disease process. An early mechanism in atherogenesis is exposure of the intimal endothelium to noxious stimuli like hypercholesterolemia, hypertension, and pro-inflammatory cytokines that disrupt its ability to function as a barrier and cause it to become activated. In their activated state, blood vessels are prone to the uptake of lipoproteins, particularly ApoB containing LDL cholesterol, from the circulating blood. These lipoproteins are subsequently retained in the arterial wall, whereby they undergo chemical modifications. The downstream effect of these modifications is a pro-inflammatory cytokine release that thereby promotes recruitment of monocytes into the vessel wall. Once inside the arterial wall, these monocytes and macrophages begin to ingest modified LDL cholesterol particles where they become lipid-laden foam cells. The aggregation of foam cells results in a yellow-colored fatty streak in the vessel wall, and with it, the first macroscopic signs of atherosclerotic disease. At first, the initial uptake of LDL by macrophages to become foam cells is actually considered beneficial, as it helps to sequester otherwise potentially damaging lipoproteins. However, over time, the ability of foam cells to properly handle and process the lipoproteins is exceeded. This causes a host of negative changes within the cell, which eventually triggers an apoptotic cascade, which is initially protective, but then becomes destructive. The eventual death of these foam cells leads to the release of an array of pro-inflammatory cytokines like interleukin-1 alpha, interleukin-1 beta, interleukin-6, tumor necrosis factor alpha, as well as matrix metalloproteinases. Unfortunately, this inflammatory storm further exacerbates atherosclerosis by promoting further immune cell infiltration, and thus the cascade continues. So let's take a look back at where the inflammatory hypothesis of cardiovascular disease started from and where we have come to by taking a look at literature in the area. To start off with, let's rewind to 2002. I think this is a good time point to begin our discussion this morning. At the time, it was noted that half of all myocardial infarctions and strokes were occurring amongst apparently healthy men and women with levels of LDL cholesterol that were in fact well below recommended thresholds for treatment. Thus, it was hypothesized that perhaps it was inflammation that was driving at least some of this incremental risk for these patients. This study from Ridker et al. In the New England Journal of Medicine really paved the way for the inflammatory hypothesis of vascular disease and looked at levels of inflammation in the form of CRP, as well as LDL levels in the prediction of first cardiovascular events. This was a massive prospective cohort study from his team. CRP and LDL cholesterol were measured at baseline in over 27,000 healthy American women who were then followed for an average of 8 years for the occurrence of MI, stroke, coronary revascularization, or cardiovascular death. They assessed the value of these two measurements in predicting the risk of cardiovascular events in the study population. In terms of their results, although CRP and LDL cholesterol were only minimally correlated with each other, with an R value that was only 0.08, baseline levels of each marker had a strong linear relation independently with the incidence of cardiovascular events. After adjustment for age, smoking status, diabetes, hypertension, and use or non-use of hormone replacement therapy, the relative risk of first cardiovascular events according to increasing quintiles of CRP as compared with the women in the lowest quintile were 1.4, 1.6, 2.0, and 2.3 respectively. In other words, cardiovascular risk increased with increasing levels of inflammation. Comparatively, the corresponding relative risks in increasing quintiles of LDL cholesterol, again compared with the lowest quintile, were 0.9, 1.1, 1.3, and 1.5, again with cardiovascular risk increasing with increasing levels of LDL cholesterol as we would expect. Importantly, overall, 77% of all events occurred amongst women with LDL cholesterol levels that were below 4.14 millimoles per liter, and 46% occurred amongst those with LDL cholesterol levels that were below 3.36 millimoles per liter. Because CRP and LDL cholesterol measurements tended to identify different high-risk groups, screening for both biologic markers provided better prognostic information than screening for either alone. Independent effects were also observed for CRP in analyses that were adjusted for all components of the Framingham risk score. Thus, this study really showed that inflammation added additional incremental prognostic cardiovascular value over and above both cholesterol levels as well as Framingham risk scores in the evaluation of our patients' cardiovascular risk. So this cohort study showed us that increased CRP and therefore increased inflammation was a marker of increased cardiovascular risk. But the question still remained whether targeting these patients with elevated inflammatory markers with primary prevention therapy could make any difference to their downstream outcomes. This led to the concept of the Jupiter trial. Since statins also lower levels of high sensitivity CRP as well as cholesterol, the Ridker group hypothesized that people with elevated high sensitivity CRP levels but without dyslipidemia might actually benefit from statin therapy. In the Jupiter trial, they randomly assigned over 17,000 healthy men and women with normal LDL cholesterol levels but elevated high sensitivity CRP levels to receive either rosuvastatin 20 milligrams daily or placebo. And then they followed them for the occurrence of the combined primary endpoint of MI, stroke, arterial revascularization, hospitalization for unstable angina, or cardiovascular death. Panel A here shows that the cumulative incidence of the primary endpoint of non-fatal MI, stroke, arterial revasc, unstable angina, or cardiovascular death was significantly reduced in the rosuvastatin group. The hazard ratio for rosuvastatin compared with placebo was 0.56. Panels B and C here show components of the primary outcome. You can see regardless of the component, there was a significant reduction of events with rosuvastatin. And then finally, panel D here shows the hazard ratio in the rosuvastatin group was 0.80 for all-cause mortality. Thus, in this trial of apparently healthy persons without dyslipidemia, but with elevated biomarkers of inflammation, rosuvastatin significantly reduced the incidence of major cardiovascular events. So in Jupiter, we had a drug that affected both inflammation, as measured by high sensitivity CRP, as well as cholesterol, which was able to push the bar forward with respect to lowering cardiovascular events. But how about medications that solely target inflammation without touching cholesterol at all? The CANTOS trial looked to answer this question. We know that the inflammatory cytokine interleukin-1 beta is central to the inflammatory response. Canakinumab is a monoclonal antibody that targets IL-1 beta and is actually used for rheumatologic inflammatory disorders like juvenile idiopathic arthritis. It's been demonstrated to lower the inflammatory cytokine IL-6 as well as high sensitivity CRP. Ridker et al. Asked the question whether the anti-inflammatory monoclonal antibody canakinumab could be used to prevent recurrent vascular events in patients that had a persistently high inflammatory response after their first cardiovascular event. So patients with a high sensitivity CRP level that was greater than 2. The patients had to be at least 30 days after their myocardial infarction, which I think is important to remember. We can't generalize these results to patients who have just had an acute myocardial infarction. They randomized them to receive placebo or one of 3 doses of the interleukin-1 antagonist, either 50, 150, or 300 milligrams. The half-life of canakinumab is actually quite considerable, so they were able to dose this drug just once every 3 months, which is pretty remarkable when you think about it. That this antibody could attenuate the production of an interleukin over such an extended period of time. In terms of their primary outcome, they looked at the composite of first occurrence of non-fatal MI, stroke, cardiovascular death, all in a time to event analysis. There was multiple testing done in the trial, so they had to correct for this, but the results for the 150 milligram dosage came out as statistically significant. Canakinumab use resulted in no significant reduction from baseline in either the LDL cholesterol or HDL cholesterol levels, but at a median follow-up of 3.7 years, the incidence rate for the primary endpoint of non-fatal MI, stroke, or cardiovascular death was 4.5 events per 100 person years in the placebo group and only 3.86 events per 100 person years in the 150 milligram canakinumab group. When you look at the Kaplan-Meier curves, there was a slight additional lowering of the curves with the 300 milligram dose, but it didn't seem to be significant. So the 150 milligram dose was kind of in that sweet spot. They saw a reduction in the endpoint, which was, again, a composite of cardiac death, MI, and non-fatal stroke. And with the 150 milligram dosage, they saw a hazard ratio of about 0.85. The secondary endpoint included all of the components of the primary endpoint, but they also added unstable angina that led to urgent revascularization. And due to closed fit testing, they only looked at the 150 milligram dosage for that key secondary endpoint, but it was also significant with a hazard ratio of 0.83. So in summary, The 150 milligram dosage of canakinumab, but not the other doses, met the pre-specified multiplicity-adjusted threshold for statistical significance, again with a hazard ratio of 0.85. CANTOS showed that we can use an anti-inflammatory medication to lower cardiovascular events in high-risk patients, but canakinumab is expensive and it also carries some risk of infection with it. The results led to the question, is it cost-effective? I wanted to look at the question of cost-effectiveness of canakinumab compared to standard of care for the secondary prevention of cardiovascular events. So I conducted a cost-utility analysis comparing canakinumab to standard of care, i.e. no anti-inflammatory therapies, for secondary prevention of cardiovascular events in Canadian adult patients with a previous myocardial infarction with high residual inflammatory burden and done from the perspective of the Canadian healthcare payer. Using the available data, I set up a Markov model, conducted a probabilistic analysis to estimate the costs and outcomes of treatment with canakinumab, again compared with standard of care, and used a Monte Carlo simulation with 5,000 replications to determine the propagation of uncertainty from my input parameters to the outcomes. And my outcomes are reported in incremental cost effectiveness ratios. In other words, this reflects what the incremental cost is to increase the health of the population by 1 quality adjusted life year. This table of probabilistic results shows the ICER obtained after running our Monte Carlo simulation with 5,000 replications, and it shows that the ICER is close to $190,000. We usually use an ICER of about $50,000 per quality as our threshold for determining if something is cost effective. Thus, this shows us that at its current pricing, canakinumab is nowhere near being cost effective from a Canadian healthcare perspective, and substantial price reductions would need to occur for it to meet this mark. This cost effectiveness acceptability curve represents the probability that this new therapy, canakinumab, is more effective than standard of care, what we have now, depending on what our maximum willingness to pay threshold is for equality. So as I mentioned, you can see at our current threshold of $50,000, there is roughly a 0% chance that it is cost effective. Hence, you can see from my analysis that canakinumab is clearly not cost effective from a Canadian perspective, and similar analyses from an American perspective are the reason why it did not get FDA approval for this indication. But importantly, the CANTOS trial was groundbreaking in that it was the first trial to show that a medication that purely targeted inflammation could actually alter cardiovascular outcomes. So it added further fuel to the question on whether other anti-inflammatory drugs could have a similar benefit. But if this were the case, we would need to find a more cost-effective agent to use. Perhaps methotrexate was the answer. Methotrexate is extremely inexpensive. It's effective for other inflammatory conditions like rheumatoid arthritis, psoriatic arthritis, and juvenile idiopathic arthritis. And finally, observational data has shown that patients with these conditions who are treated with methotrexate actually have fewer cardiovascular events. And just to emphasize that last point, the systematic review and meta-analysis of observational trials looked at the effects of various anti-inflammatory medications, including methotrexate, on cardiovascular events in patients with rheumatoid arthritis, psoriasis, and psoriatic arthritis. In the interest of time, I won't go through all of the results, but I wanted to pull out the results for methotrexate. This review showed that a meta-analysis of 8 observational trials showed a significant reduction in cardiovascular events with methotrexate with a pooled relative risk of 0.72. This information spurred the CERT trial, a randomized placebo-controlled trial which looked at low-dose methotrexate for the prevention of atherosclerotic events. They were specifically looking to answer the question whether methotrexate could reduce recurrent cardiovascular events in patients with diabetes or metabolic syndrome and stable CAD. Methotrexate acts in a number of different manners, but importantly, it inhibits interleukin-1 beta by binding to its surface cell receptor. This is its primary anti-inflammatory mechanism. This was a multi-center trial with over 400 participating sites, including Ottawa, which randomized patients to receive methotrexate 20 milligrams PO/Q weekly or placebo. All participants completed a run-in phase of drug as well as regular folate supplementation. At trial initiation on April 4th, 2013, the primary endpoint was the first occurrence of MACE, being a composite of non-fatal MI, non-fatal stroke, or cardiovascular death. And then in January 2018, after review by the National Heart, Lung, and Blood Institute, as well as another external panel, The trial point was actually endpoint was actually expanded to include hospitalization for unstable angina, and they did this again to just allow for greater power and smaller overall sample size. When you look at the Kaplan-Meier curves for their outcomes, you can see that there were no differences between the placebo and methotrexate groups for both the final primary endpoint as well as the original primary endpoint. After a median follow-up of 2.3 years, methotrexate did not result in less inflammation, as measured by interleukin-1 beta, interleukin-6, as well as high sensitivity CRP levels, and it also did not lower the incidence of the primary endpoint. The SEARCH trial showed that low-dose methotrexate didn't reduce atherosclerotic events, but it also didn't reduce markers of inflammation, so it neither confirmed nor refuted the inflammatory hypothesis of atherosclerosis. The authors noted that a significant difference between SERT with methotrexate and CANTOS with the canakinumab was that the canakinumab trial by design included patients with a higher baseline inflammatory risk, as evidenced by a persistently elevated high sensitivity CRP level. The median CRP level in CANTOS was 4.2, and it was only 1.6 in this SEARCH trial with methotrexate. The main takeaway is that anti-inflammatory therapy may not have an impact if A, there isn't a lot of inflammation at baseline, or perhaps B, if the agent chosen actually doesn't decrease inflammation. So we were still on the hunt for a cheaper method to target cardiovascular events through an inflammatory pathway. Lodoco was a study out of Australia that was published in 2013 and set to look at whether colchicine could take on this role. Colchicine is a potent anti-inflammatory medication that's been used for centuries and is used in a variety of inflammatory conditions like gout, pericarditis, and juvenile idiopathic arthritis. It acts by inhibiting tubulin polymerization and microtubule generation, cellular adhesion molecules, inflammatory chemokines, as well as the inflammasome. In this clinical trial, with a prospective randomized open-labeled observer-blinded endpoint design, 532 patients with stable CAD receiving optimal medical therapy were randomly assigned to either colchicine 0.5 daily or no colchicine, and then were followed for a median of 3 years. The primary outcome was the composite incidence of ACS, out-of-hospital cardiac arrest, or non-cardioembolic stroke. The primary analysis was by intention to treat. This figure shows freedom from the primary outcome by treatment group, and it yielded a hazard ratio of 0.33 with a number needed to treat of 11. Lodoco showed us that in patients with stable CAD who were treated with colchicine 0.5 milligrams PO daily, there were fewer cardiovascular events than in those patients not receiving colchicine. However, there were multiple issues with this trial. Firstly, it was a small trial with only 522 participants. It was also not placebo-controlled, it was not blinded, and they also arbitrarily added patients to the colchicine arm to replace dropouts. So this paper was largely considered hypothesis generating rather than practice changing. The Colcutt study wanted to establish the role of colchicine in treatment of CAD in the setting of a well-run randomized placebo-controlled trial. However, they went for a higher risk group and actually targeted patients who were post-MI. This was a multi-center trial. Patients were randomized to placebo or colchicine at a dose, again, of 0.5 milligrams PO daily. There were over 4,700 patients enrolled, and only 1.9% were lost to follow-up, which is quite impressive. I think it's important to point out also that at the end of the trial, 18.4% of the participants in the colchicine arm dropped out because of perceived side effects, while 18.7%, the exact same number of placebo participants, dropped out because of perceived side effects. Notably, these participants were all patients who had suffered a myocardial infarction within the past 30 days and who were otherwise on good optimal medical therapy. Their primary efficacy endpoint was a composite of cardiac death, MI, resuscitated cardiac arrest, stroke, and urgent hospitalization for unstable angina. The mean duration of drug receipt was roughly 1.5 years, and follow-up duration was approximately 2 years. It's important to note that these were moderate risk patients with the placebo event rate being around 7%. Otherwise, the baseline characteristics were similar in all the groups, placebo and colchicine, with a mean age of 60 years. Roughly 30% of the participants were smokers, and there was good overall adherence to goal-directed medical therapy. 7.1% of the placebo group had an event, while only 5.5% of the colchicine group had an event, for a hazard ratio of 0.77. It's also important to note that while the point estimate for all components of the primary endpoint trended favorably towards colchicine, the primary outcome was largely driven by stroke as well as unstable angina. The rate of adverse events was exactly the same in the placebo and colchicine groups. And when we think of adverse events with respect to colchicine, we typically really think about adverse gastrointestinal events. I think this slide is super telling. Look at the rate of adverse events in the colchicine group and the placebo group. They were exactly the same. Lastly, I will point out that there was a signal for more pneumonia in the colchicine group. So in this randomized double-blind placebo-controlled trial, colchicine was associated with fewer cardiovascular events than placebo amongst patients with recent myocardial infarctions. Importantly, colchicine was not associated with increased diarrhea. Interestingly, colchicine did have a signal for a higher rate of pneumonia, and whether this was due to chance or by altering immune function remains to be seen. And finally, the mechanism of action of its benefit is not known. Perhaps it's acting through the inflammasome, or perhaps it's acting through some other yet undiscovered mechanism. Now, Colcut was targeting patients with recent ACS, but what about patients with stable CAD? Nydorf and the researchers that published Lodoco 1, which also looked at colchicine in stable CAD, but you'll recall they did it in an unblinded fashion and without a placebo control. They wanted to, again, take a look at this patient population, but perform their study in a proper randomized double-blind placebo-controlled fashion. They enrolled over 6,500 patients in an open label run-in phase. Roughly 1,000 patients dropped out during that run-in phase, and about 60% of those dropouts were due to perceived side effects. So in the end, just over 5,500 patients underwent randomization to receive either colchicine 0.5 daily or placebo. The primary endpoint was a composite of cardiovascular death, MI, ischemic stroke, or ischemia-driven coronary revascularization. The key secondary endpoint was a composite of cardiovascular death, spontaneous MI, or ischemic stroke. Again, a total of over 5,500 patients underwent randomization, half to colchicine, half to placebo, and the mean duration of follow-up was 28.6 months. A primary endpoint event occurred in 6.8% in the colchicine group and 9.6% in the placebo group, yielding a hazard ratio of 0.69 for colchicine. I want to point out that the incidence of death from non-cardiovascular causes was actually higher in the colchicine group than in the placebo group, with a hazard ratio of 1.21. It's an interesting point which I'll touch a little bit on later as well. However, in summary, in this randomized trial involving patients with chronic CAD, the risk of cardiovascular events was significantly lower amongst those who received colchicine 0.5 daily than amongst those who received placebo. As you can see, evidence on our potential ability to target inflammation as an effective means to reduce cardiovascular risk has continued to mount in recent years. Colchicine seems to be a very promising agent, which has demonstrated cardiovascular outcome benefit in a number of different trials. However, these exciting results are also tempered by a signal for increased harm. Colchicine is but one of several anti-inflammatory drugs that have recently shown promise. However, the unifying theme amongst these agents is that they all carry some increased risk of harm with them. In particular, colchicine has shown a signal for increased risk of non-cardiovascular death in a number of different studies. This table is taken from the Lodoco 2 trial. Again, you'll recall their primary outcome of cardiovascular death, MI, ischemic stroke, and unstable angina showed benefit for colchicine. However, many have pointed out that there was a trend for increased all-cause mortality in the colchicine arm. And similarly, the COPS trial, which was a multi-center randomized double-blind placebo-controlled trial that looked at colchicine in post-ACS patients, also showed a signal for increased all-cause mortality, albeit with extremely low numbers. So it's difficult to determine at this point where the scale should settle out with respect to risk and benefit from colchicine. The CLEAR Synergy trial is a randomized control trial which will hopefully shed some light on this issue. This study will look at the long-term effects of treatment with colchicine as well as spironolactone following PCI to treat STEMI. This is a 2x2 factorial design looking at colchicine and spironolactone and is run out of PHRI in Hamilton. The primary outcome for this trial is a time to event of the composite of cardiovascular death, recurrent MI, or stroke over the duration of their follow-up. The planned number of patients is 4,000, so it should shed a lot more light on the issue of all-cause mortality and colchicine. So that's an overview of where we have come from in the field of anti-inflammatory therapies for cardiovascular disease. But how about next steps? I've shown a lot of evidence for anti-inflammatory therapies in cardiovascular disease, and I think a key takeaway is that while there's a lot of promise in the field, there are still a lot of questions to be answered. A clear path forward has not yet emerged. Perhaps the answer will be to stack the deck in our favor. Instead of treating all patients with colchicine or any other anti-inflammatory drug for that matter, perhaps we should be targeting high-risk inflammatory subgroups. I think an important step in this realm of research is to identify patient subgroups that we feel will benefit most from potentially novel anti-inflammatory therapies. To that end, I wanted to point out some of the work that I have been involved with that has tried to push the bar forward with respect to identifying and characterizing some of these high-risk subgroups that may in the future benefit from anti-inflammatory therapies for cardiovascular risk reduction. As I've tried to emphasize throughout the presentation, vascular inflammation is now recognized as a major contributor to cardiovascular disease. This is especially the case in patients with diabetes. Diabetes is a metabolic disorder characterized by high blood sugar and impairment of the body's ability to use said sugar in the blood. This itself has been recognized as an inflammatory process. From an overall risk perspective, we know that patients with diabetes have a higher risk of future cardiovascular events after suffering a myocardial infarction compared to other patients. So we felt that perhaps patients with diabetes would be a perfect subgroup to target with anti-inflammatory therapies. However, currently the prevalence of inflammatory markers such as high sensitivity CRP post-vascular event have not been widely studied. If we were to identify that patients with diabetes who have suffered a heart attack or stroke have particularly highly elevated inflammatory markers after their event, it may indicate that we should be specifically targeting this population with anti-inflammatory therapies in the future. We posited that the prevalence of increased high sensitivity CRP as well as interleukin-6 as markers of vascular inflammation in patients with diabetes or prediabetes following a recent cardiovascular event would be greater than in a control group of patients who had a remote cardiovascular event. For our small study, we took patients coming into the Heart Institute or through the stroke clinic and separated them into two groups, either patients that had a recent cardiovascular event, so within the past month or two, or patients that had a remote event, so it had been over a year since their heart attack or stroke. And then in this recent cardiovascular event group, we separated them further into two subgroups. Group 1 were patients that had diabetes or prediabetes, and Group 2 were patients that had no dysglycemia. For groups 1 and 2, again, the acute event groups, we measured their inflammatory markers within 2 months following their cardiovascular event. And then for Group 3, the remote cardiovascular event group, we measured their inflammatory markers over a year since their cardiovascular event. We found that the median IL-6 value between the group with diabetes and a recent vascular event was significantly higher than in the remote group. And similarly, we found a numerical trend of higher CRP values in the group with diabetes and acute events compared with the other groups. So this is congruent with what other literature says and supports the notion that diabetes is linked with inflammation. Given that patients with diabetes and prediabetes have a higher inflammatory burden and are already at higher risk for recurrent vascular events, we felt that this specific population may be an ideal group to target with therapies aimed at the reduction of the inflammatory burden, which led to our idea for the Cadence study. I've spoken quite a bit about colchicine during the past hour, but another question that remains is the mechanism of action of colchicine. It's actually unclear how colchicine mediates its effect on potentially reducing cardiovascular events for patients. So we wanted to answer this question by targeting high-risk patients who have diabetes and who have suffered a recent cardiovascular event to see if we could determine the underlying mechanism of action of this drug by harnessing our expertise with vascular inflammation imaging that we have here in Ottawa. Our project, again titled Cadence, which has already started enrollment, is a multi-center RCT evaluating the efficacy and underlying mechanism of action of colchicine in the reduction of cardiovascular events by utilizing Fdg PET imaging. Specifically, we're recruiting diabetic and pre-diabetic patients who have recently suffered a cardiovascular event, We're randomizing these patients to receive either placebo or colchicine for a period of 6 months. And then we're looking at the change in vascular inflammation as measured by FDG PET in these patients with treatment with colchicine after their acute event. The big question is how to measure inflammation in the heart. Imaging biomarkers are a perfect method to do this. Specifically, PET imaging, which utilizes radioactive nuclear tracers co-registered with CT images, can use these radiolabeled tracers that bind to specific targeted molecules within tissue beds and can provide insight into biological processes like plaque inflammation. Furthermore, literature has shown that decreases in aortic inflammation with therapies is actually a strong surrogate marker for a reduction in cardiovascular morbidity. So just as a shout out to all the clinical facing staff, if any of you have any patients with diabetes or prediabetes, so an HbA1c of 6 or greater, that have suffered a recent myocardial infarction, so unstable angina, NSTEMI or STEMI, just send an epic message to either myself or Chantal Lefebvre or Ali Ahmadi, some of our research coordinators that are involved with this project, and we would be happy to screen the patients and see if they're eligible for recruitment. This slide lists some of the other big anti-inflammatory trials that are underway at present. Firstly, the Clever ACS trial is a phase 1 to 2 RCT looking at everolimus in patients with STEMI. Their primary outcome is infarct size in patients administered everolimus. Secondly, the All Heart study is a multi-center prospective randomized open label study looking at the effect of allopurinol in patients with known ischemic heart disease, and their primary outcome is a composite of non-fatal MI, non-fatal stroke, or cardiovascular death. The COAX trial is a phase 3 RCT looking at the effect of low-dose colchicine on all-cause mortality, MI, and ischemic stroke in patients with ACS. I've spoken already about the Synergy trial earlier, which will look at colchicine in patients with STEMI. And then finally, the CONVINCE trial will look at colchicine in patients with ischemic stroke. I'll touch now on some other work that I've been involved with to better define inflammatory high-risk subgroups. Firstly, I'll highlight some work that I've done in trying to characterize vascular inflammation in patients with psoriasis. Observational data has shown us that psoriatic arthritis and cutaneous psoriasis have both been linked with an increased risk of adverse cardiovascular events. We hypothesize that central vascular inflammation, as measured on FDG PET imaging in the ascending aorta, would actually improve in these patients following therapy with biologic agents. We studied 3 patient cohorts. So cohort 1 were patients with psoriatic arthritis or cutaneous psoriasis who were started on biologic agents. Cohort 2 was a group of patients with psoriasis who were treated with non-biologic agents. And then cohort 3 were actually a group of patients with non-inflammatory arthritides like osteoarthritis. The primary outcome of our study was the change in vascular inflammation, which was estimated by FDG PET in the ascending aorta at baseline compared to 6 months of follow-up. Analysis of covariance testing revealed the change in vascular inflammation was not equal in the 3 groups, and post-hoc pairwise comparison with Bonferroni correction revealed that the reduction in aortic inflammation in the psoriatic arthritis group treated with biologic agents was significantly greater. So biologic agents in inflammatory conditions may help to reduce inflammation in the heart, and who knows, perhaps they may also reduce future cardiovascular events. This remains to be seen. I've also done some work in patients with HIV as well. It's now known that HIV is an inflammatory disorder, with HIV infection being associated with persistently increased vascular inflammation, immune activation, and procoagulant effects, even despite treatment of the virus. Accelerated atherosclerosis observed in HIV-positive patients is thought to in part be due to a state of persistent systemic inflammation. These patients are at an increased risk of cardiovascular disease, and in fact are 2 to 4 times more likely to suffer a myocardial infarction. Cardiovascular disease actually accounts for 10% of all deaths in this patient population. Since we know that patients with HIV have a higher risk of heart disease, and HIV itself is an inflammatory disorder, perhaps some of the higher risk that we see in patients with HIV is mediated by inflammation. And perhaps if we treat this inflammation, it could potentially lower this risk. Tawakol had a similar question and actually looked at mitigation of inflammation with a single dose of canakinumab in patients with well-controlled HIV. In this pilot study, you can see over a period of 3 months, inflammation in the bone marrow and aorta was significantly reduced in patients treated with a dose of canakinumab. We wanted to see if we randomized patients with HIV and a moderate Framingham risk to statin therapy, could we reduce vascular inflammation? Of note, these are patients that would otherwise not be treated with statins. Thus, HIV positive patients with a moderate Framingham risk score were enrolled in the study and were randomized to treatment with rosuvastatin or usual treatment for 6 months. FDG PET imaging of the bone marrow, spleen, and thoracic aorta was performed at baseline and then 6 months. In terms of our results, there was a significant reduction in bone marrow, spleen, and thoracic aorta FDG uptake in the statin-treated group compared with the control group, seen here in the black circles. This is what the FDG imaging of the aorta, bone marrow, and spleen looks like respectively, and you can see in this image panel, the images look less inflammatory, aka orange, from baseline on the top to follow up on the bottom. While in this image, the control group, the images are equally inflammatory at baseline and follow up. All right, so that concludes everything I wanted to touch on this morning. Certainly the future is bright in the field of potential novel anti-inflammatory therapies for the treatment of cardiovascular disease. In terms of takeaway points, remember inflammation plays a crucial role in the pathogenesis of atherosclerotic cardiovascular disease. Evidence continues to mount regarding novel anti-inflammatory therapies for cardiovascular disease. And finally, perhaps in the future, we will preferentially target high-risk inflammatory subgroups with these therapies. I'd like to thank you all for your time and attention. I'd also like to say a very special thank you to my TAC committee and mentors for their ongoing support and guidance. And at this point, I'd welcome any questions from the audience.
Kevin, thank you so much. That was exceptional. I'm glad we have some time because we have a lot of questions. So we'll just start. The first question is, colchicine is not covered by the Ontario Drug Benefit Program, only by the EAP or Extraordinary Access Program, which requires an application. The cost is approximately $30 a month. Do you know if there's an application to have it covered under ODB?
So I'm not aware of an application to have it covered at the moment, but I'll actually be doing, as part of my thesis, a cost effectiveness analysis of colchicine in the Canadian healthcare population with Dr. Doug Coyle, who's a member of CADITH. So we'll be looking at cost effectiveness of colchicine and for this indication.
Yeah, I guess fortunately it's relatively inexpensive compared to a lot of current therapies for cardiovascular disease. Next question, is there any evidence that diet may affect inflammation? Example, fast foods versus foods rich or high in antioxidants?
Yeah, that's a good question. You know, across my review of the literature, to this point, I've mainly focused on drug therapy, but it's an interesting question whether you know, diet and as mentioned, kind of highly processed foods may have an impact on inflammatory burden. Certainly, I haven't. So the short answer is I haven't come across anything to that effect, but again, I hadn't specifically gone looking for that, and it wouldn't surprise me if there is literature out there that's investigating that. But the short answer is I haven't personally seen that, but I'm sure there's literature out there.
Okay, so we'll all just eat a cup full of blueberries every day prophylactically.
Perfect. Yeah.
Yeah, okay. So next question from Dr. Catino, actually. I'll just read you her comment. Kevin, what a great overview. Congratulations. I always knew that there was a preventative cardiologist in you. So her question is that knowing the substantial risk reduction that can be achieved with lifestyle and behavioral modifications, is it sufficient for RCTs of anti-inflammatory drugs to simply use a placebo as the control group?
So I think, you know, it should be noted that all of these, it's a very good point, Dr. Coutinho. It should be noted, though, that all of the patients in the trials are, undergoing optimal medical therapy. And, in the trials, I don't know if that includes cardiac rehab programs or whatnot. They don't specifically mention that. Again, a lot of the focus are on, for better or for worse, on drug therapies. So, presumably at baseline, both the placebo and treatment groups are, being treated equally, aside from, the drug versus placebo. But you're absolutely right. I think patients should be aggressively targeted, with the non-pharmacologic therapies that we have available to us for secondary cardiovascular risk reduction. And there's evidence out there that shows a link between brain, bone marrow, and an immune system that may be a driver for cardiovascular disease in patients. So certainly healthy brain, healthy body, healthy heart is certainly important.
Next question is from Dr. Golian, who comments on your mustache, and he has mustache envy. But his question is, considering the group of patients benefiting from anti-inflammatory use have constant background elevated inflammation levels compared to their counterparts, and the fact that patients may have side effects from the anti-inflammatory medications, is there any thought about whether these medications are discontinued? Will there be a rebound effect and then an increased risk of major cardiac events? And if so, what duration of time should these patients be treated for? Or is this, should this be indefinite therapy?
Yeah, no, that's an awesome point. And firstly, Dr. Golian, we can talk offline, and I can give you some mustache tips to help you on your way. And then with respect to the, it's a great point. I don't think this area is, fully understood yet, and why some patients have a higher inflammatory burden than others, remains to be seen. And certainly, it's a very good point that if we stop these medications, these anti-inflammatory medications that do have risk and do have side effects with them, we stop them in the future for these patients that have, some baseline inflammatory risk. Will they have a rebound effect from their discontinuation, and a rebound effect from their inflammatory levels rising again? I don't think we know the answer to that question. And same thing with respect to how long to continue the therapies. I don't think we know the answer to those questions.
Our next question is from Dr. Liu. His comment: great presentation and congratulations on your progress in your research. His comment is that it's interesting that Paul Ridker presented the rescue trial at ACC evaluating ziltivimab, which is an IL-6 inhibitor, in advanced renal failure patients, which showed very effective lowering of inflammatory biomarkers. And they're now launching a trial called the ZEUS trial in this regard. Do you think the future will use biomarkers such as IL-1B or IL-6 to identify patients who may benefit preferentially from anti-inflammatory therapy?
Yeah, no, it's a great point, Dr. Liu. Thanks for the question. And I think research has shown that these inflammatory markers do identify high-risk groups, and certainly, research has shown that having elevated inflammatory markers is a prognostic marker that independently of other kind of risk scores. So I think certainly in the future, I do see a role for either blood biomarkers or imaging biomarkers to help risk stratify patients and identify those that could potentially benefit from anti-inflammatory therapies. Being mindful of the fact that currently there's, we have wide array of drugs that patients typically leave the hospital on post-MI. So we do have to be mindful and really trying to select patients that will benefit most from these therapies that, again, do have some, they're a double-edged sword with some side effects and risk of harm with them, I think is an ideal way forward. So I absolutely do see a future role for that.
A few more questions, Kevin. This is from an anonymous individual. Why do you look at the ascending aorta with PET rather than the descending aorta, where we see much more extensive atheroma? And have you compared ascending versus descending aorta PET inflammation? Yeah,
great question. There's been a lot of work in this area, and specifically the, so ideally we would target coronary vessels with Fdg PET imaging, but the coronary vessels are so small that we can't accurately image them. So we use the ascending aorta kind of as a surrogate marker for inflammation in the heart. Theoretically, it's a neighbor. It's very close by, and the resolution is good, so we can actually accurately image it with Fdg PET imaging with CT. In terms of ascending versus descending, I think it alludes to that point that it's a neighbor to the heart. But additionally, the work in the area has all kind of centered around the ascending aorta, and I made a reference to it during the presentation, but specifically, inflammation reduction in the ascending aorta has actually been prognostically linked with reduction in future cardiovascular morbidity. So current work in the field, the norm is to use ascending aorta. It would be interesting though to look at comparing the inflammation changes in the descending aorta as well. So I mean that's an awesome idea, and I'll certainly look into that with the kind of cohorts that I have. Great question. Thank you.
Question from Dr. Ross Davies. What is the role of inflammation post-CABG, which is another high-risk group, and is this group being studied?
Yeah, awesome question, Dr. Davies. I think certainly I think the risk is similar to, so two parts. So post-CABG, in an ACS setting, we're enrolling those patients in the Cadence study. So certainly that patient population is being studied. Post-CABG, in a stable CAD setting, I think that would fit more under the realm of the Lodoco banner in terms of stable CAD. Certainly the CABG itself is going to be an inflammatory process. But we've already shown benefit in stable CAD patients that have inflammatory burden in several of those trials that I mentioned, including Lodoco. So I certainly do think that there is a role for anti-inflammatory therapies also in that patient demographic as well.
Do you recall what dose of Crestor was given in the HIV study?
Yes, yeah, so it was 10 milligrams.
Okay. And you commented on one of your slides that there was an increased non-cardiovascular risk with colchicine, or a signal for that anyways. Is there any work being done to identify, which patients are at risk of these non-cardiovascular events, so that we can kind of stratify?
It's a good question, Dr. Stadnik. I'm not aware of any studies trying to look into that further. That doesn't mean that they're not going on. They very well may be. I'm just not aware of any. But it is a point to make note of, and certainly I think once we have more patients in randomized trials with colchicine, I think we'll have more data available to look at that question. And the Synergy trial, I think it's 4,000 patients that they're enrolling, so that should lend a lot more data and a lot more granularity to the data, where we can kind of tease that apart. Which patients are, if there is a patient demographic that does have a higher risk of side effects and morbidity from the colchicine versus other patients.
And yeah, along those same lines, Dr. Garuba was wondering if mechanistically we knew what the cause of these side effects were. Like, was it related to myelosuppression from the colchicine? Do you have any sense of what's triggering these events?
Yeah, so great question, Dr. Garuba. So again, this is just all like postulation at this point. I don't think, firstly, I don't think we know the mechanism of action of colchicine in terms of its mediating benefit in the heart, which is, the whole premise behind our Cadence study. In terms of the harm, certainly colchicine does modulate the immune system. And anytime that you're modulating the immune system, you're increasing risk of infection and whatnot. Other immune modulators like methotrexate, for example, they saw a higher rate of cancer in patients treated. So certainly my thought is that that risk is deriving from its modulation of the immune system. Where exactly the end result is, I don't think we know. But yeah, it's certainly interesting and something that we'll have to keep an eye on. Thanks, Dr. Garuba.
Well, I'll turn over the moderator role to Dr. Beanlands for some final comments. But thank you very much, Kevin. That was exceptional. And as you can see, there's a large amount of interest from the audience.
Awesome, great. Thank you, guys. Thanks, Dr. Stadnik.
Yeah, great presentation, Kevin. Really comprehensive and covering the field and so on. And as Dr. Stadnik noted, lots of engagement from the audience. So great to see that, and thank you everyone for that as well. Just a couple of side comments that I think with the Cadence trial, we're only treating for 6 months. So I think the question about short and long-term treatment is highly important. So there does need to be more information on that and more data. And I think the rebound question is a good one as well. And we don't have an answer for that, but we're going to have to watch for that for sure. In terms of the descending aorta, there is evidence that so Tawakkal's probably one of the world leaders here, and he is now doing that in some studies, and there are a couple of studies that have looked at it, but in general, as you pointed out, Kevin, it's the ascending aorta where the differences have been observed that have been linked to outcomes. So I think there's more to come with the descending aorta. I think the burden of atherosclerosis is so large that it may be so much larger there that it just may be harder to potentially demonstrate differences with the imaging, at least with Fdg imaging. And likewise, as you pointed out, we do want and need the ability to image the coronaries, which we can't do with Fdg, although there are some tracers that are being explored. Anyways, I think it was a fantastic presentation and greatly appreciated. Congratulations and good luck with all your ongoing research. Great work, Kevin.
Great. Thanks so much. Thank you.
Can I ask you to stay on for 1 minute after?
Of course.
As well. Or maybe, yeah. All right, thank you. Andrew, are you